All right. Okay, guys. So for everyone that just joined, this is the emergency room technician at Triage Education. What we really want to talk to you guys about today is the why behind triage. Why are we doing triage? Why did we introduce the role of the triage tech? Why did we introduce the role of the greeter? And how we all have to kind of work together.
Yeah, sure.
Why we all
Orientation.
okay, sorry, it's okay. So why we're all gonna have to work together for this one goal. The role, everyone does it differently, and we understand that, but we really are trying to streamline it, and maybe with your guys' more understanding of the process, you can help with that. So the purpose is to educate the emergency room techs to the following new roles of ED screener and triage technician, to introduce and evaluate a new process to the staff, and to facilitate an atmosphere in which encourages input, feedback, and active participation. So anytime you guys have a question during this, either say it or raise your hand or we'll get it done. Because I think with you guys in the role, you could also help with when we introduce a new process, you know, the process is a plan laid out, but it always has to be tweaked. So the process will never fully work if we don't go back in a month or so, tweak it, fix it until it's fully developed. So what are good qualities of the triage nurse or the tech? And I think that's really important to have certain qualities. And I think you guys probably know that from working with a whole bunch of different nurses and with each other in the triage role. And so you have to understand the emergency nursing standard of care. And it's, you know, also your role that you understand the same things. You have to have strong critical thinking, assessment, and interview skills. That with communication, I think, is the key to triage. Understanding the hospital's policy and procedures, the departmental flow and treatment areas. Having the ability to multitask and collaborate with your team members. Communication, leadership skills, and then certifications. BLS, ACLS, PALS, CN, ENT, THCC, ATCN. So I guess when you have those skills, triage becomes easier for you and you're able to get the patient in and out. What's the goal? The goal is to rapidly gather data to make a decision to get the patient to the right level of care at the right time, to the right place, and the right person. And I think that this is so, so important for you guys to understand. So this is why we say don't interview the patient before they see the nurse, because the nurse has to interview the patient, physically have an assessment, and look at their vitals. So those are the three main components of triage in order to get to the patient, to the right person. So is it a doc or is it a physician assistant or an NP? The right time, is it an ES 1, 2, 3, 4, or 5? To the right place, could they go to fast track? Do they have to go to 11? Do they go to a regular room? And the right level of care. And that's your ESI level as well. So one thing we want to talk about is the ESI. So some people ask me, what is ESI and what are you actually looking for? So ESI is evidence-based. It helps us to prioritize the patients, and it's supported by both the American Physicians, College of Physicians, and ENA. And as all of you guys know, ESI has 5 different levels. Okay, so what helps us determine it is the interview. Very important that you guys hold off interviewing the patients on entrance to the ED because we need to ask specific questions that will help determine their ESI level. We need to do the visual assessment of the patient. What are we looking for? Their physical appearance, their work of breathing, and their circulation. And then we have to also look at their vital signs. Are they normal? Do they need sepsis? So that's what we're looking at. So what is an ESI level 1? This is the patient that automatically goes right to the back. So this patient requires life-saving measures. What type of life-saving measures? Cardiac arrest, respiratory arrest, an overdose, that's breathing less than respiratory rate of 6 or below, a major trauma, severe respiratory distress with gasping. So those are things that, do we see them at the front door? Very rarely, but we do once in a while. So in that case, you know, even if you're letting someone out of the car and you see it, you really should stop the triage nurse to interject and say, what are we doing with this person, and get them in the back. They don't need to be received up front. Nothing has to happen. They just have to go right in the back. T2s are a high-risk situation with the potential of becoming critical. So that potential is where we're differentiating between a 2 and a 3. So it's looking at the patient, asking the questions, the vital signs, the whole situation. Could this person go into respiratory distress? Does this person need the immediate care? If these are all yes, then they really should go back sooner rather than later. But if the answer is no, they're deemed more stable and they could wait. So when we get to an ESI2, I think one of the main things is, you know, somebody comes in with chest pain. Do we just bring them in the back, or do we get the triage nurse? We should always get the triage nurse just to do a quick physical assessment, even if then we send them to the back. So what are things that are ESI2? Chest pain. But then when we look at the chest pain, is it the 7-year-old guy clenching his chest, or is it the 30-year-old guy that's on his phone and who's had it for a week? So those are the interview questions we need to ask before they go in the back. And that could take all of 2 seconds. It doesn't mean that.
Sorry, I found generals. I found Jen. I was looking for the class. Sorry.
So it doesn't mean that.
Sorry, Jen.
It's okay. It's okay. So basically, they need to be seen by the triage nurse. Sexual assaults, ectopic pregnancies, GI bleeds. Are they symptomatic? Are they asymptomatic? Do they have an appendicitis? Severe allergic reactions. So those type of situations that have the potential of becoming critical are deemed ESI2. What is an ESI3? Then we say they are stable. At this moment in time, the patient does not have that potential. And then we make them a 3. Then we kind of look and say, okay, this person is stable. How many resources does this patient actually need? So when we look at the resources, 2 or more, it's a 3. 1 resource, it's a 4. 5, no resources, it's a 5. Does anyone have questions regarding ESI? Okay.
No.
Okay. So then we might say,
Yes.
what are the all right, go back. What's the question?
Why are psychs always T2?
So if somebody says that they are suicidal or homicidal, they are a T2. If somebody comes in and says, I have a history of depression and I stopped taking my meds and I haven't left my bed in a week, And then our first question, while we interview the patient, first we're looking at them. Are they disheveled? Do they look like they're well kept? That's our physical visual assessment. We're going to ask, are you suicidal? Are you homicidal? That is your potential right there. So if they say yes, they're a 2. If they say no, then they could be a 3. And then we look at their vital signs as our third part of that.
If
So
should like technically come down quicker to see them?
we didn't hear that.
I said if they're a T2, shouldn't come down. If
So
they're
if they're
out of suicide.
so if they're a T2, basically a T2 that goes into room 11 for some sort of medical treatment alerts the team that they need to be within that room to start caring for them within a 15-minute time frame. It technically, according to ESI, if a psych patient is a T2, yes, the nurse and the ER doc or the advanced practitioner should be in the back seeing the patient within that same time frame. So a suicide or homicidal patient should be looked at the same way as someone who is hemodynamically unstable. Because
You said interesting.
yes, it is interesting. I know that it doesn't work a lot like that sometimes, but that's technically when we make them a T2 because they have a situation. So is a sexual assault patient. A sexual assault patient should always be a T2, should always go in the back because we need to provide a safe atmosphere for those patients. We should never tell a sexual assault patient, well, now we have state nurses here, which is great, but we should never tell a sexual assault patient, go to the medical center because you're going to wind up there anyway. We need to provide a safe environment for all of these patients.
I got a question.
Go ahead.
How many vital signs need to be out of range for somebody to be like a T2 who's in like severe pain?
So severe pain. So they're saying my pain is a 10 out of 10. You're looking, once again, your visual assessment. This is why I know when I'm in triage, I like to visualize the patients. Your visual assessment is like 50% of your triage level.
Right, yeah.
Look at the patient. Are they on their phone and eating, or are they doubled over? Are they crying? So it's the whole picture. So if somebody says, I interview them, I have a 10 out of 10 pain. Then I interview them, do you have a past medical history? Yes, I have a history of kidney stones, and I think I have one now. So there's my interview skill. I'm looking at him or her, and they're doubled over in pain. There's my visual assessment. They're sweating, they're diaphoretic. Then I take their vital signs, and they're tachycardic, and their blood pressure is like 200 over 100. Then yes, that is probably a true T2 in pain. But then if someone says, yes, I have kidney stones, and I have an ache on my left side, and I have some blood in my urine, I think I have it again. How's the pain? It's a 10. But their vital signs are within normal limits. They're physical, they appear okay, then I'll make them a 3.
Yeah, what if it's not as clear cut though? For like not a kidney stone. If it's like someone's like, oh, I have abdominal pain, and they look uncomfortable, and their heart rate's over 100, and their respiratory rate's over 20. They're not like a T2, are they?
So the rule of thumb is that you're going to interview them, but what do you have as a medical history or anything? It's really a call at the situation. If somebody has like a history of kidney stones or cancer, then I'm more apt to making them that T2. If they really look like they're in that much pain and their vital signs are backing them up, according to TSI, they should be a 2.
I got you.
And in the world that we live in, most of them are going to be a T3.
Yeah, I got it.
Because most of them, they say their pain's at a 2, and they might be physically showing signs, but their vital signs really aren't, showing that picture. That also comes into play if you're 80 years or above, you're automatically a T3 no matter what your diagnosis is. And that's what we do in our ER. And if you're 1 or under, you're automatically a T3 no matter what. And the reasoning behind that is that the hospital would like the providers to see those patients. And you're actually then, you're taking away what ESI says, and it's really more the provider lays eyes on these patients at some point. Any other ESI questions or questions on how we get to ESI? All right. So when we talk about resources to get our stable patient a 3, 4, or 5, this is the resource list. So somebody comes in with a fracture and they slam their finger into the car door. And they have an open lac. Well, what are the things are we going to do for that patient? They're going to automatically need an x-ray, correct? And then there are a simple lac repair, hopefully. So those are 2, so they should automatically be a 3 out of 4. Mary went skiing and she fell down the mountain, and 2 hours later she winds up in the ER with her wrist injury. What is she getting? An x-ray. So she's our 4. Bob and Beth come in because they're on their 3rd vaccination of rabies. They're 5. Tetanus, PO meds, med refills are not resources. So that's what we're like, once we've developed in our heads, okay, this person does not have that potential and they are stable, we have to say, what is the diagnosis? So in my head, I'm talking to you and I'm interviewing you and saying, okay, this is probably an API workup. What do we have to order? And that makes me say, is it a 3 or a 4 or a 5? So my API is going to get labs. My API is going to get an x-ray. If it's a peds API, it's going to get an ultrasound. They're going to get some IV fluids. They might get some IV Zofran for nausea. They might need a GI consult. So I'm automatically going to make them 3 because it's 2 or more resources. So knowing your signs and symptoms, your diagnoses, and your treatments is really the key to triage. And that's why it's so important for us to interview the patients and having that time with them. Because then we could determine exactly where they have to go and what provider has to see them. And that's the key. Any questions on resources? So across the room assessment, and this is what we're looking at. We are looking at general impression of the patient, their appearance, their work of breathing, and their circulation. So we have that chest pain let's say we have a UTI. And the patient's 70. Do they have urosepsis or do they have a UTI? So, you know, what is their circulation? What's their work appearance, work of breathing? This is what we're looking at. This is having the triage nurse out there, keeping an eye on every patient. We as our provider, our license, everything, we are taking responsibility of all those patients sitting in the waiting room. So if we have 5 people in the waiting room, we have to constantly be visualizing those patients. Sometimes we do have an elderly person there with a fever. Do they look gray? Do they are they hypotensive? Are they tachycardia? How long can they sit out there? All right, and this is what we're constantly looking at. Are they conscious? Are they lethargic? Are they being carried into the ER? Pain, moaning, crying, laughing, talking to oneself, disheveled, rash, unusual dress or makeup. Do you hear stridor, wheezing, gurgling, breathing, increased rate of breathing, circulation? Anyone doing CPR, abnormal skin color? Are they diaphoretic? Are they hemorrhaging? So that is our visual assessment. So interview, vital sign, visual assessment, knowing and anticipating your diagnosis, your treatment, your signs and symptoms are all the key to triage. So the triage nurse is doing all of that in their head, and that is the why behind triage. So now we're introducing your guys' new role. Any questions regarding the why before we go into that? All right. So the screener. So the screener or the greeter, one of the purposes of this person is to always be at the ER door, especially now during COVID, since that door is locked. We do not want patients waiting in the vestibule. We want them to be acknowledged right away. So having you free in that aspect and not doing vital signs or receiving patients and having that line of people developing gets us to very early recognition of the patient. They're acknowledged and what's going on. And I know this is difficult because once people hit that vestibule,